Good afternoon. I'm pleased to welcome everybody to the Bremer Institute biweekly seminar. This is our first of the fall. So it's a great privilege and pleasure that not only is this our first seminar of the fall, but it's also one of the Hutzler-Rives Memorial Lectures. Let me just say, welcome. I'm Jeff Kahn. I'm the director of the Bremer Institute of Bioethics for those of you who don't know me. And welcome to fall of 2021. So before we introduce today's speaker, let me take a moment to acknowledge the individuals who made this lecture series possible and to give you a little bit of background on the naming. Eleanor, who went by Ellie Trowbridge, was a member of the Bremer Institute's board, and she was very committed and interested in palliative care for reasons you'll understand in a moment. Ellie devoted much of her time to Johns Hopkins, not only as an employee, but as a volunteer. She served in the university's development office and raised critical gifts and support for the Department of Oncology. She chaired the Johns Hopkins Bloomberg School of Public Health's Council on Population and Family Growth, and served as a development consultant for the Children's Defense Fund and Population Action International. In 2003, her efforts on behalf of Johns Hopkins were recognized through her being awarded the university's Heritage Award for Outstanding Service. She served on the Bremer Institute's board until her death in 2007. Her commitment took on deeply personal significance with the death of her daughter, Sheila Hutzler-Rives, who succumbed to breast cancer in 1988. So this semi-annual lecture series, we do 2 of these a year, as that would imply, is therefore named for Sheila and focuses on longstanding and emerging ethical issues in palliative care. And so we're grateful for Ellie's generosity and for the generosity of her family. So that's the naming and the reason. And as you'll hear in a moment, maybe nobody better to talk about those issues than our speaker today. And to introduce Professor Tulsky, let me turn things over to my colleague, Joe Ali, who will introduce our speaker and the talk for today. Joe, over to you.
Thanks very much, Jeff. It's a pleasure to introduce our speaker for our kickoff seminar for the year. And couldn't have a better speaker for this topic than Dr. James Tulsky. So I serve as the chair of the seminar committee for the Bremer Institute, and just wanted to mention gratitude to other members of the committee, including Mary Catherine Beach and Alan Regenberg, as well as Suzanne Knisner's support. But let me introduce our speaker today. Dr. Tulsky is the chair of the Department of Psychosocial Oncology and Palliative Care at Dana-Farber Cancer Institute. He's also chief of Division of Palliative Medicine at Brigham and Women's Hospital and professor of medicine and co-director of the Center for Palliative Care at Harvard Medical School. After receiving internal medicine training at UCSF, he did the Robert Wood Johnson Clinical Scholars Fellowship and was from 1993 until 2015 on the faculty of Duke University, where he last held a professor position in medicine and nursing. He was the chief of Duke's palliative care at the same time. He's been a recipient of a number of different really prestigious awards, and I'm just going to mention a few because they really are reflective, I think, of the great work that Dr. Tulsky has been doing in the field. But he was a recipient of the 2002 Presidential Early Career Award for Scientists and Engineers, which is the highest national award given by the White House Office of Science and Technology for Early Career Investigators, and the 2006 Award for Research Excellence from the American Academy of Hospice and Palliative Medicine. Additional awards received from the George Engel Award for the George Engel Award from the American Academy on Communication and Healthcare was awarded in 2013 for outstanding research and contributing to the theory and practice of teaching effective healthcare communication-related skills. So perhaps unsurprisingly, a lot of Dr. Tulsky's work relates to doctor-patient communication and quality of life in serious illness. He's published very widely and notably on this topic, including evaluations and enhancements to communication between oncologists and patients with advanced cancer, identifying clinical, psychosocial, and spiritual trajectories of patients at the end of life. So he's also a founding director of Vital Talk, which is a nonprofit devoted to nurturing healthier connections between clinicians and patients through communication skills and teaching. So with that, I'm going to hand over to Dr. Tulsky for today's seminar, which is titled Thinking Again, Is Advanced Care Planning Obsolete? Dr. Tulsky, over to you. Thanks.
Great. Thank you so much, Joe and Jeff. It's really a pleasure to be here at Hopkins. I was so hoping that we thought early on this might actually be a face-to-face visit, which would have been a lot of fun. I have many friends and colleagues there, but unfortunately not yet. It's still great to be a part of this. Also, I just wanted to acknowledge and also thank the family of Ellie and Sheila Hutzler-Rives. I'm not sure if any of them are in the audience, but if so, I want to express my gratitude for the support of this talk. So let me go ahead and share my screen and start these slides. And as you can see, my talk is entitled Think Again, Is Advanced Care Planning Obsolete? I hope that this title was as controversial as it meant to be, and we'll see what you think by the end of this. So where I'd like to start is I want everyone in the audience to think about a time when the evidence changed your belief about something. And this could be something in your personal life, but I'm honestly thinking a little bit more about your professional lives. And something that you thought was true, and then you read research and other kinds of evidence, and you came to believe something different. So I want you to think about that for a moment, and then I'm going to ask if you're willing to do this, to go to the chat and click to everyone. And if you can just write, one line about what it was that you changed your mind about, or what it was that caused you to do that. You don't need to write a paragraph here, but just something quickly that you can get into the chat. So I would really welcome that if people can think about a time when the evidence changed your belief about something. Treatment for infants with trisomy 13/18, great. I'm guessing this had something to do with different outcomes. That's from Renee. Hi, Renee. It's good to see you out there. Medical marijuana. I'm curious about which way that went. The evidence is very interesting in that area. First aid palliative, tramadol was a good choice for pain management. Yes, tramadol really got kind of dinged for a long time, and it's actually a little better than we might think it is. Margarine. Okay, I think that's probably that margarine's no better than butter, but I'm not sure. Great, so some wonderful examples. Use of race, the meaning variable in biomedical research and clinical practice. Oh, super, Gail, thank you so much. That is a biggie, right? I think personally I was, raised just like we didn't even think about it. We talked about race in, for example, hypertension studies. NICU team would rather have preemie than a septic baby. That's an interesting one. I would probably want to have more of a conversation about. Taking a baby to parents' beds. And I'm curious, I don't know the evidence on that, so I'm curious which way that goes. Need for annual mammograms. OxyContin, non-addictive pain med. We have definitely learned otherwise, haven't we? Lack of evidence to support colloid. For volume resuscitation of the critically ill, yes, just saw that article. Or is that, yeah, that was the one that was recently published. Need to administer oral 6-MP without food or drink. Don't know that one, but sounds an open heart surgery for 80-plus-year-old patients when my grandfather needed it. Interesting. Implicit, yes, implicit bias and microaggressions. So I could, hopefully some more will come and I could continue reading these, but we get the idea. I'm going to actually go ahead and share mine. So for me, that moment was back in 1991. It was this article. And I was just starting out as a fellow and as a research fellow, actually. And at the time, our belief was, well, of course, most of you know that ventricular tachycardia is a dangerous cardiac rhythm that can lead by itself to death and oftentimes to ventricular fibrillation. And the belief in the field was that obviously this is bad. You wanted to suppress it whenever possible because it was such a toxic rhythm. And in fact, you wanted to suppress PVCs, premature ventricular contractions, that were known to sometimes lead to ventricular tachycardia. So they did this huge national randomized controlled trial, enconide, flecainide, and a third drug, morsazine, and they checked it against placebo. And what they found was the patients who were, and this drug was created to suppress PVCs. And what they found was that the patients with this drug died more frequently than the patients who received placebo, completely reversing our thinking about this. And it was a moment, not just for that particular intervention, which was, interesting and important, but it was the first time I kind of really came to get that an RCT could change something in our minds, and the evidence could be that important. So based on this idea that we might be able to think again, what I'm going to talk about today is a story about how my beliefs have changed. And they've changed about something called advanced care planning, and I'm going to talk more about that. I know most of you know a lot about it. And the part that's really hard here is that much of my life's work has been devoted to increasing advanced care planning, increasing advanced directives, getting more of those out there into the community. I've done lots of research on this. I've done lots of advocacy. I've done lots of teaching. And yet, at the end of a fairly long career of doing this, I'm actually believing something very different today than I believed before. And I will say I believe it's the minority opinion. And I'm here to try to actually get this out there, maybe change some minds in this audience. So what do I now believe? I now believe that the science does not support advanced care planning as an intervention to improve end-of-life care. And secondly, I think we need to rethink our investment in advanced care planning and focus instead on what works. So hopefully that was the controversy. And I wanted to just get it out there right up front. And now I'm going to spend the rest of the talk making my case. So first of all, at this point, I do want to say that I have no conflicts. Not that there would be a lot of conflicts in this area necessarily, but I want to make that clear. If anything, my conflicts go the other way, in that I'm probably associated with lots of different kinds of programs. And I actually even still have a large NIH-funded study looking at advanced care planning, so that my conflict goes in the direction of actually supporting the thing I'm saying I don't believe in anymore. But I do have some acknowledgments, and I want to acknowledge these three people: Sean Morrison, who is the chair of geriatrics and palliative care at Mount Sinai; Bob Arnold, who is the chief of palliative medicine at University of Pittsburgh; and Diane Meyer, who's also at Mount Sinai and formerly was the head of the Center to Advance Palliative Care. These three colleagues and I have had a lot of conversations about this. We actually hosted a meeting at the National Academies of Science, Engineering, and Medicine roundtable on quality care and serious illness. We hosted a meeting on this topic. And we wrote a paper that is coming out in JAMA sometime in the next few weeks. I'm not sure when it's going to be out, on what I'm going to talk about today. So I want to let you know that. Well, actually, we wrote the paper together, but when we submitted it, we then learned that they will only accept 3 authors, not 4. So we flipped a coin, and actually they're the 3 authors and I lost. But that's okay, because that probably means that I won't have to wear the flak jacket that they will have to be wearing as we walk around. Okay. So what is advanced care planning? In this audience, I understand that, this is something that most of you probably well know, but I'm going to give a definition for our purposes here. And what I'm going to say is that it's a process to support adults in understanding and sharing their values, goals, and preferences regarding future potential medical care decisions. This is the key word here. It's about working on about getting these preferences and goals out today for a decision that's going to happen sometime down the road. What does advanced care planning include? Choosing and preparing a trusted person to make medical decisions, or a healthcare proxy. Preparing for future conversations, like what would it be like to have that conversation? Having conversations about actual future treatment choices, like I would or would not be on a ventilator. Documenting wishes so that they can be acted upon when needed. And this may end up in a variety of different kind of products that come out of advanced care planning. One is a healthcare proxy form. Another is an advanced directive, or formerly often referred to as a living will. It could result in clinicians documenting conversations in the medical record, and it can result in something called either a POLST or a MOLST or a MOST form, which is a physician or medical order for life-sustaining treatments. These are out-of-hospital medical orders for things like do not resuscitate. Again, I'm fully aware that you guys are probably mostly familiar, but I just want to get clear on all that. Okay. So what is the goal of advanced care planning? The goal is to ensure goal concordant care near the end of life for patients who lack decisional capacity. Now, some people may argue about that, but I think that's really what we're trying to get at. We want to make sure that the care that people get, and they're getting that care at a point when they can't make the decision in the moment, that it is reflective of what would have been their goals going in. What advanced care planning is not, and by the way, I'm going to use this ACP abbreviation through the rest of the talk. I am not talking about in-the-moment decision-making, and this is really important because I completely believe in high-quality in-the-moment decision-making. That is, sitting down with the patient and having a good, thorough, goals-based, shared decision-making kind of conversation with someone about a treatment decision in front of them, whether it's, whether or not to continue chemotherapy or go into hospice or a do not resuscitate order. Any of those things it's in the moment decision making, and also in the moment decision making with families and surrogates is also counted. And I'm not talking about any kind of palliative care intervention, or that's, advanced care planning is not. People say that part of palliative care is advanced care planning, and perhaps that's correct, but that is not the same as what I consider an active palliative care intervention when a palliative care team is talking to a patient and family, usually about in-the-moment decision-making. And the reason I'm differentiating here is because these things do work, and we've got good scientific evidence to show that these actually work. I'm talking about the advanced directive sort of work. Okay. So a little history. Again, I think all of this is probably some review, and then I'm going to get to the part that maybe is less of review, but a little history about how we actually got here. This all started, probably in the 60s, maybe a little bit before, with awareness about issues around death and dying in general. Elizabeth Kuzma-Ross was doing work around then, and others. Dame Cicely Saunders did her work. People were becoming more aware. And this man, Louis Kuttner, was a lawyer in Illinois who was gave a talk in 1967 at the Euthanasia Society, where he advocated for the idea of what he called a living will. And what he basically said was that if we could have an estate will, then we ought to be able to have a living will to determine what else happens to our bodies and so forth, and not just our property. And he actually extrapolated and used legal theory about how to create that idea. And he advocated that. So the first living will statute was created in Illinois 2 years later in 1969. The next step was to create this thing called the durable power of attorney for healthcare, there already was a durable power of attorney where I could assign somebody else the ability to do my bank affairs, let's say, if I was incapacitated. But this was a durable power of attorney for healthcare, which was I could assign someone to make healthcare decisions for me should I become incapacitated. And the first one of these laws was passed in California in 1983. And then a few things happened. Now, if somebody wants to, in the audience, throw into the chat quickly who they think this is, or if they recognize who this is, I'm actually curious. You get like 10 seconds to do this. if anybody's going to recognize this person. All right. Karen Quinlan, good job, guys. So Karen Ann Quinlan, it's interesting because when I give a talk, for example, to medical students, and I ask, don't even show the picture without a name, but I actually ask, who is Karen Ann Quinlan? I get like 1 or 2 hands going up. But for people of my generation, she was a household name. And Karen Ann Quinlan was a young woman who ended up in a coma on a ventilator persistently. She ended up that way because she had a combination drug and alcohol overdose. And there was a long drawn out issue about whether or not her family could withdraw the ventilator. And she finally died in 1985. And then after her, some people had, one person said, that it was Nancy Cruzan. It wasn't, but Nancy Cruzan came later. And another young white Catholic woman who also ended up, in her case, from a car accident in a persistent vegetative state. And there was a very big issue for many years around whether or not their feeding tube could be withdrawn, and it finally was. I've often, this tombstone of hers has been photographed often because there's a few things about it. First of all, the way at the very top, the thank you looks kind of like an EKG line that is going to flatline. And then at the bottom, how they say departed in 1983, which is when she had her accident, but she did die actually until 1990. And the case, these were 2 cases of, tragic cases of young women who people could sort of identify with. They got a lot of press. It motivated people to think about, well, what would happen? Is there any way that I could protect against me lying in an ICU bed or me lying with a feeding tube for years and years and years because my family won't be able to take it out because the law won't allow them to do that? So this motivated really a lot of the push toward advanced directives, with these cases. And I say this because, these are the cases that motivated it, and yet this is not kind of how it actually plays out or how they're actually used. And what this led to was something called the Patient Self-Determination Act, which was passed in 1990, enacted in 91, I believe. And what this did was that all hospitals that receive federal funding, which is almost all of them, need to let patients know on admission that they have the right to make these kinds of decisions. So, as most of us know, this was a fundamental thing that we put forward, and really hospitals had to start providing people with advanced directives and the opportunity to complete them and so forth. A lot of push to do this work. And then after that, something else that followed was that in 2016, CMS actually passed a ruling that allowed physicians to start billing for advanced care planning. So in the face of like mea culpa on this, I was part of this. So in 2014, the Institute of Medicine had a committee that wrote a report on end-of-life care, and I was on that committee, and I actually wrote the section that, among other things, advocated for this. And now I actually think it was a mistake. But it was, that the advanced care planning would be paid for to do this, and you could do this with anybody. It didn't have to be somebody who was older or whatever. Okay, I'm just going to talk for a couple of minutes about the uptake of advanced directives. So this is just how many adults have advanced directives in the population. This is the data through 2016. And as you can see, these are a variety of different surveys that have been done over the years, but it's never really exceeded much beyond around 40% of adults with advanced directives. One could argue that that's actually, not bad. And this is by no means an argument that one should not do them, just the fact that you can't get them done. But it is a small percentage, or at least it's certainly not a majority of the population. And if you look at specific populations, look at people with HIV or cancer, renal disease, and so forth, you can see that, with the exception of neurologic disease, I think that's mostly probably dementia and maybe other kinds of neurologic diseases, and then to some extent renal disease, the numbers are also fairly low, even in people who are living, for example, with cancer or heart disease. So how far this is actually penetrated is still a bit of a question. Again, that's not an argument not to do it, but it's just an observation. And this is despite a huge amount of public advocacy around this for 30 years. So I guess one point I would make here is that I don't believe we're ever going to get the numbers beyond this. So that is a point to consider. So let me just say why advanced care planning is so attractive. I've given a history. I've sort of talked about how it got to us. I know it's just in the water for most of us in our health systems and many for us in our practices. And, first of all, what I would say is that conceptually, it makes sense. And from an ethical perspective, and I'm talking here at the Berman Institute, it honors patient autonomy and self-determination. It allows the current self to dictate the outcomes of the future self. Now, I know there's a whole very interesting literature on that, and whether or not the current self and the future self are actually different people, and whether or not one can dictate to the other. But I do think that most people want to be able to control what happens in their lives throughout, even through death and beyond, which is the reason we have wills, which is the reason people dictate what they want their funerals to look like, what's going to happen to their remains after they die. So conceptually it makes sense. I don't think anybody can argue with that this being sort of a natural inclination we would want to do. The other thing is, and you may fall on different sides of this question, but it reduces low value care. Sorry, I thought there was another bullet below that. So, and the point here is that, or there's a belief that it could reduce low value care is what the attraction is. And this is particularly the health systems that think they spend a lot of money on care that they believe people would not want, or that some people believe is non-beneficial, or the language, people have often referred to as feudal care, and that's another conversation. But if you can prevent that, that seems to be a good thing. I mean, assuming it aligns with the person's goals. Another notion about it is you would imagine it might prevent decision-making conflict. If when you have to make a decision about somebody's life-sustaining treatment, and you already know what they want, hopefully the family, the clinicians, everybody will be able to get more closely on the same page. So this would be a goal. And we would hope that it would reduce the burden on caregivers and surrogates. It's for those of you who are active clinically and work in these kinds of areas, how spectacularly difficult it is for caregivers, surrogates, family members to make these sorts of decisions for their loved ones. So, and then finally, why should we care about the idea of whether or not it's effective or not? Because we might say, well, advanced care planning makes sense. And all the things I just said, and it makes ethical sense, and it feels like the right thing to do, and it's respectful of people. And so therefore, let's just keep doing it. Why should I be here talking about it and saying maybe we're making some wrong choices? Well, we've invested over $30 million in federally funded research from 1990 to 2020 on this topic. It's about $1 million a year, and that's federally funded research. If you add in the research funded, from foundations and otherwise, it might be double that. The other thing is there have been numerous public initiatives promoting its use, most of which, by the way, advocate for advanced care planning, regardless of age or health status. All these public awareness campaigns, respecting choices, all sorts of other groups out there. Now we're getting into the hundreds of millions of dollars, I'm sure, at least, I've not seen it quantified, advocating for advanced directives and advanced care planning. The other thing is now, as I mentioned before, physicians are being paid to do this. Annual Medicare wellness visit, and you can tack on the advanced care planning code to that and make a little bit of extra money and have the conversation with people. So, at the end of the day, this is now costing the government and costing us that much more money. And then the other thing is that CMS and private payers are using advanced care planning as a quality measure. And so this is starting to get really important. And by the way, I will say that the paper we're having coming out in JAMA is really focusing on this issue about the role of a quality measure, because this is important. If we're going to actually judge health systems and decide how people get paid and so forth based on that, then that's going to be important. So this is a very long lead up to now explain where the problem is. And I'm going to spend the next, 15 minutes or so sharing some of the evidence around this, around advanced care planning, and why it leads me to be thinking again. So first of all, there is a substantial evidence base for advanced care planning. In the last 30 years, there have been over 6,000 peer-reviewed articles published on the topic. So we don't have a paucity of research. There have not only been a number of articles, there have been a number of systematic reviews. And in this case, this is actually a review of systematic reviews. So there have been, sorry, my little clicker is, there we go, not working. There have been 80 systematic reviews evaluating 1,600 original articles on this topic. And then in this review of the reviews, if this is making sense, what they determined from that, looking across all of these reviews, was that advanced care planning interventions may increase advanced directive completion. They may increase advanced care planning discussions that are had. So if you do these interventions, these are outcomes you can hope for. They may improve knowledge of the participants. And they may lead to documentation of less aggressive treatment choices in a document. In other words, if I have a certain kind of intervention where I'm talking to you and teaching you about the concept, and then I look at what choices you pick on a document, you'll be likely to pick less aggressive choices after many of these interventions. What ACP interventions don't appear to do in any, after they've reviewed all of this evidence, is improve concordance between patients and surrogates, improve satisfaction or reduce anxiety of patients or surrogates, influence real-time medical decision-making at the end of life, enhance goal concordant care. And I know I'm going to refer to goal concordant care a few times, and some of you may say it's impossible to measure, and I agree, it's a very hard concept to measure, but when in the various ways people have tried to do it, they've not found it, or improve patient family perceptions of quality of care received. So this article, although the spin is not quite the way when you read it as I'm describing it, if you look deep into it, it's somewhat damning. Okay, so that was in 2018. And that was a pretty comprehensive review of reviews. There was another article that was done by McMahon et al. And published in JAGS, where they now looked at 62 high-quality articles. This was a scoping review, sort of a different process here, just in the last 10 years. And what they saw was that these interventions, they found that they could have positive effects on patient surrogate satisfaction with communication, patient surrogate clinician congruence. By the way, this is different than the other one, so maybe there was more congruence there in decision-making. And they found some reduced surrogate clinician distress around decision-making. Fine. But what they also found that there was no relationship identified between advanced care planning and goal concordant care or patient quality of life. And most importantly, there was no relationship identified between advanced care planning and subsequent healthcare utilization or use of non-beneficial treatments, which is most likely what we're looking for. Now, I appreciate that, the lower use, if goal concordant care was for everyone to have aggressive care, then you would not have less non-beneficial treatment being used. I get that. And yet most of these directives are filled out in the direction of less aggressive care. So you would expect the care to go in that direction. Okay, so that was all pretty convincing. But over the last 2 years, there have been 4 large randomized controlled trials I'm going to review reasonably quickly here that suggest, more of the same. And these are really well done studies. So this first one was advanced care planning in patients with advanced cancer. And this was a large study done in 6 countries, Belgium, Denmark, Italy, Netherlands, Slovenia, and the UK. They enrolled over 1,100 advanced cancer patients in 23 hospitals in these countries. And the program they used, and this is actually maybe the one that is most meaningful to me, because the program they used was Respecting Choices, which is your classic advanced care planning program, of sort of like getting people, counselors to work with you, get your ideas out, fill out a document, an advanced directive sort of document, and get that into the chart. And the people who are doing it are themselves, they may have clinical backgrounds, but they're not actually your clinicians. So this is kind of classic advanced care planning. Now, this isn't advanced care planning with anybody. This is with people who already have advanced cancer. So they took sick people here and put them in. It was a very carefully done cluster randomized controlled trial. I'm not going into the details of these studies. I welcome you to look at them, and we can argue sort of how some of them were done. What they found was that there was no difference in the intervention versus control groups in quality of life, symptoms, coping, patient satisfaction, or shared decision-making. The only thing they found signal in was that there was a slight increase, and this was statistically significant, in palliative care referrals, 37% versus 27%. By the way, those numbers are very low anyway. And advanced directive inclusion in hospital files from 3% up to 10%. Again, very low numbers. So this is what they found. So basically, this huge program, and there are many Respecting Choices programs all across America, had very little effect on the things that we would have hoped to have seen. This is another study that was published in JAMA Internal Medicine this year of a nurse-led advanced care planning intervention for vulnerable older adults. And in this study, there were 759 patients who were over the age of 65, and these people had a number of comorbidities. That was how they determined vulnerability. They did a randomized controlled trial of a nurse navigator advanced care planning pathway. So not so dissimilar from the Respecting Choices model, although it was with clinicians who were involved in the patient's care. And what they found was that there was a higher rate of advanced care planning documentation. So like other studies before, we can get people to fill these forms out if we work at it. But there were no differences in emergency department visits or hospitalizations for these patients. And that, by the way, was their primary outcome. And they didn't see a difference. And what was kind of amazing to me was that if you read the article, and these are the results, and they're very clear, in the conclusion, they argue that what they've come up with is a scalable approach to advanced care planning. And I read that, and I had kind of a take back, because that's a positive spin. And yes, they were able to get a lot of people to do it, but at the end of the day, it didn't work. And so it makes one wonder, why do I want to scale something that doesn't work? The next study was on advanced care planning videos for nursing home residents. And full disclosure here, this study was done by a team of investigators. Susan Miller is the first author, but one of the other investigators was Angelo Volandes, who was a collaborator with me on a study we're doing. We're using his videos in a cancer patient population. It's a little bit more about in-the-moment decision-making, and we could have a conversation about it, but I just want to make that disclosure here. This looked at 360 nursing homes in 32 states. These were long-stay residents with dementia or advanced illness. There was a pragmatic cluster randomized controlled trial, meaning clustered by nursing homes, with nearly 10,000 patients in the intervention group and 20,000 in the control group. This was a tour de force of getting this project done, quite an extraordinary effort. And what they found was that in their primary outcome of hospital transfers, there was no difference in the primary outcome. And there was also no difference in burdensome treatment or hospice enrollment. So hospice enrollment wasn't higher, and burdensome treatment, things like feeding tubes for these people, was no lower. And by the way, I may not have been clear about the advanced care planning videos. These are videos that sort of describe what it is to have a living will, what different kinds of choices might be that you would consider in the future. Their point about this would be that it failed because the fidelity to the intervention was very low, between 0 and 40%. In other words, they rolled out this intervention, and yet many of the nursing homes never actually implemented it. So one could say it didn't work because people didn't actually get the intervention. That's a completely valid argument, and yet in the context of research, when they were sort of funded to do this and they were working as hard as they possibly could, they still couldn't get it to work, which I think leads us, to sort of think a little bit about that. And then the last study I'm going to mention came from Scott Halpern and Penn, and published in JAMA Open also last year. And here what they did was they looked at advanced directives with different kinds of default options, and they gave them to seriously ill patients. And they enrolled 515 patients with serious illness. These were 20 outpatient clinics, 2 academic medical centers. They gave them 3 different kinds of advanced directives that either had a default checked for either comfort, a default for life-extending treatment, or neither, to see whether by giving a default, this is kind of a nudge, behavioral economics sort of perspective, to see whether it would make a difference. What they found was the different defaults did make a difference in the choices people made. So if your default is toward more aggressive treatment, you're more likely to choose that. If your default is toward comfort care, you're more likely to choose that. But what they found was that their outcome, which was hospital-free days, like not getting admitted, was no different between the groups despite what was checked as a desire. So in other words, in this large randomized controlled trial, there was absolutely no difference in outcomes based on patient-stated preferences in the advanced directive. And this is the one study that actually had the conclusion that I would want to see people have from these, where they wrote in their study and in their discussion, current policies and practices that encourage the completion of conventional advanced directives, oops, there's a typo there, I apologize, may not improve the quality of end-of-life care. So they actually said the point I'm trying to make. So what is the summary of all these data? A strong body of evidence shows that some interventions can increase knowledge of advanced directives and advanced care planning in patient surrogates and healthcare providers, the number of advanced directives completed, the likelihood of advanced directives in the medical record, and the number of advanced care planning conversations, as well as satisfaction with the advanced care planning process itself. At the same time, there's little to no consistent evidence from high-quality studies showing that advanced care planning influences end-of-life care for patients without decisional capacity, enhances quality of death and dying, increases the likelihood that end-of-life care is goal concordant, improves patient surrogate satisfaction at the end of life, or improves surrogate quality of life or bereavement outcomes. The things that I would consider to be the distal outcomes we really care about. So what does my experience show? I was going to share several stories here of these patients, Jan and Zach and Andrea. I continue to be an active palliative care clinician. I have an outpatient practice in a busy cancer center. What I will say, just for lack of time, because I really want to hold some time, hopefully, for questions. Each of these stories, I'll maybe pick one in the middle, which is Zach, who was a lawyer, very strong thoughts about what his care should look like. He had advanced prostate cancer. He had such strong thoughts. He was actually an advocate of medical aid in dying. He had rented an apartment in Vermont because he wanted to be able to go to Vermont and have a death at the time and place that he wanted when the time came. So very strong feelings about what he wanted in the future. He also wanted to continue to get any kind of active treatment that was going to keep him alive as long as he thought that his life was worthwhile. We kept struggling with this balance about, when should he or shouldn't he stop treatment, and went back and forth and back and forth. And his own decisions unfolded over time. He was very ambivalent. He was basically weighing two different kinds of things constantly. And eventually what happened was that he got too sick to really make a decision. He couldn't get himself up to Vermont. It all fell on his wife to try to make the decision. He had been as explicit as you possibly can about what his preferences were, and yet she continued to agonize over all the decision-making because there was so much ambivalence and so many different ways to think about it. And finally, at the end, we were able to enroll him in hospice, and finally, he did die at home. But the point only was that even in someone who had very clear ideas about how things should go, because of his own indecision, his own ambivalence, and that of his family, it wasn't going to play out exactly how he might have thought it would. And this was even as he was living through it. The other stories kind of have similar levels of this kind of ambivalence and how it plays out over time. So this leads to sort of, why does advanced care planning fail? Treatment choices near the end of life are, not simple, consistent, logical, linear, or predictable. And that just makes it all that hard. Instead, they are complex, uncertain, emotionally laden, which is an important piece here, and they are fluid. The other thing is that patients' preferences are rarely static. They're influenced by all these things: age and their physical and emotional function, their culture, preferences, family preferences, clinician advice, financial resources, caregiver burden. All these things play a role. The other thing is that surrogates struggle to extrapolate treatment decisions in the present from hypothetical discussions in the past. I mean, most people just can't do this. Even if it's written on a piece of paper, they can't do it. They can't figure out I cannot tell you the number of times I've heard families say, I don't know if this is what he was talking about, whatever this is. The other thing is that when a decision must be made, prior directives are often absent or poorly documented, too prescriptive, or too vague. And treatment choices do not occur in a vacuum. They're driven by financial pressures, by societal capacity to support patient and family needs, and institutional regional cultures and practice patterns. So, given the evidence I've just suggested, why does it persist? Why is the opinion that I'm stating so minority? And I can tell you that, having spoken at with my colleagues and various other venues and the National Academies meeting we have, people get very upset about this, and they continue to say, no, we just have to study it more. We just haven't figured out the right outcome. We just something, right? Well, I think there's a number of reasons why it still persists. First of all, advanced care planning appears to be the ethically correct thing to do. So you don't want to go against something that kind of seems like it makes logical/ethical moral sense. I think we really have a need to believe that we can control what happens to us. And if there's anything I've learned, particularly I will say in the last 6 years working at Dana-Farber and doing outpatient palliative care in a cancer setting, we can't control it. Commitment bias, and then escalation of our commitment. What's commitment bias? We tend to be consistent with what we've done or said in the past, particularly if we put that out into public. It's very hard to have been, running programs about advanced directives and then say, well, I did may not be working. And then there's confirmation bias, which we tend to search for, interpret in favor, and recall information in a way confirms or support our prior beliefs. That's that conclusion I showed you from that nursing study, where the conclusion was we can now scale advanced care planning, instead of the conclusion being it didn't work. And the lack of alternative approaches. I think people don't know what to do if we don't do this. It's kind of better than nothing. What's at risk here? Well, a few things. First of all, we're diverting resources from what works to what doesn't. And I think there are things that work. Second is a belief that completing an advanced directive will prevent future undesired treatment. I cannot tell you the number of people who hand me an advanced directive and think that's going to guarantee that things are going to go exactly the way they want. And I have to explain to them, it might look a little different than this. And inhibition of real-time high-quality discussions because of poor prior ones. In other words, somebody comes in with an advanced directive, we just pay attention to that, and we don't have a conversation right now, and I put COVID there, because in the worst of COVID stress in New York and in Boston, where I am, this was happening, where conversations were sometimes not had because old forums were trusted, and that may not have been the right way to go. So what should we do? And I'm near the end of what I'm going to say here. I think, first of all, there are some pieces that I think are useful. I do believe the appointment of a trusted surrogate is a good thing. And I think you want to know who do we need to talk to in that time, and you want somebody that you can trust. I think we need to focus on improving in the moment shared decision making. That is when the decisions happen. That is important, and that still is fraught. Those conversations are still highly problematic in lots of places. I think we're getting better, but we can do a lot of work to make that better. I think that we can prepare for the conversations without engaging the content. In other words, I think it's useful to talk to patients or family members about what it would be like to have a conversation about this in the future. What would you need to know? What do you want to be thinking about? What sorts of things might be important, but not to actually lock in on decisions, but to prepare for the idea of a conversation that will happen in the future. And then I think from a quality measure perspective, we need to identify new quality measures. Patient-reported outcomes, feeling heard and understood, and receiving desired help for pain are an interesting option. Post-death surveys of surrogates might be an interesting option for quality measures. This is kind of a whole quality discussion, but I think that's something else we can be doing. This is a schematic that was at that conference, the National Academies conference I mentioned before last year, by Derek Hyland, who's critical care doc in Canada. And he here sort of talked about other things that we can be thinking of, none of which are actually advanced directives. And but this is kind of like from the far left to the far right, which is kind of moving toward end of life. You have early conversations that are decontextualized just about future health and illness in general. Choose a substitute decision maker. You can have those preparing conversations, thinking about illness understanding, prognosis, goals, fears, trade-offs. Those things should be gotten out there so we have some understanding of the person as a person. And then as time goes on, have in-the-moment decision-making about specific things that are actually occurring. And then eventually at the very end, you will end up with things like most and post when that time is appropriate. And finally, I'm going to end here. I've been highly influenced by this book by Adam Grant. If you haven't read it, I strongly commend it to you, called Think Again. He's a wonderful writer in general. In this book, he talks about how we tend to not do this enough, to not rethink what we believe based on the evidence. And he says the purpose of learning isn't to affirm our beliefs. The purpose of learning is to evolve our beliefs. And if we think about that, and we want to truly be scientists in how we work forward, then we're always going to be testing and what happens and seeking the new truth as it emerges. So I would actually argue that the history of advanced care planning is the history of science working. That if we were to choose to abandon some of the things we currently do, because the evidence shows they don't work, that's actually great science. It's the reason we did all that research in the first place. But to simply use confirmation bias and to simply say we're going to do more of it, I think is highly problematic. So at this point, I will stop. Not as much time I wanted for questions. Sorry about that, but I'm happy to have this conversation at this point.
Thanks so much, James, for the really, really engaging presentation. I'm sure everybody is applauding virtually. We have just a few minutes, maybe 5 minutes. So if colleagues would like to raise a question, you can post it in the Q&A pod or module, or you're welcome to raise a hand and we can try to unmute you if you'd like to speak. But let me just take the first one here from Renee in the Q&A. So Renee, thanks you for leading us through the talk. In her experience, ACPs make space for values, cognitive processing, but end of life is all about emotion and distress. How do we, or should we, elaborate our values in the end of life scenario?
So I think that so I don't have a problem, and I also see there was another comment here about preparing for conversations without engaging in content. And I think both of these are connected. I don't have a problem, and I think early on to have conversations, particularly in the setting of questionable prognosis, to say, what would it mean to you? What does this mean? What is most important to you as you think about the future? What kinds of things? To sort of try to get a sense of what is most important. Where I think it gets problematic is trying to translate that into specific treatment decisions that are going to be enacted in the future. I think that's the part that's problematic. When we then get to the end of life stage, where it is about emotion and distress, so the first thing, as Renee knows well, we have to manage that emotion a lot. And we need to try to do all sorts of, use our best communication skills there to do that. And then hopefully, if possible, reflect back on early conversations. So, for example, I do have those conversations earlier with my cancer patients and document that in the record. And then later on, when things are getting tougher, I'll say, remember we had the conversation and you said this. How does that inform your thinking now? It's all clouded by emotion, but hopefully that can actually help. And people will often feel, I had a patient say to me once, early on, I had an early visit with her and she had a brain tumor. And I was visiting her in her hospital bed before she was about to get hospitalized, operated on. And after we had the conversation about it all, her husband looked at me and said, I get it. You're the guardian of our values. And I so loved that because I think that was what we were trying to get at.
So just a couple more comments or questions here. Nikki is asking if you could please elaborate on your recommendations to prepare for a conversation. I'm not sure if they're your recommendations or your colleagues, but to prepare for conversations without engaging in content.
Yeah, I think the idea here is to think about what would it be like to have the conversation in the future. There's a whole number of different ways to think about this. One level is what I just talked about. That is, I think the content we're talking about here is the actual decision-making content. So you can talk about values and goals and what's important without that. I think there's also a piece about how hard is it for you to talk about and why is it scary? And we have some tools like opening the box and closing the box, and can you talk about it in the future? So I think that would be the other piece is can you imagine when you would be able to talk about it and what that would be like for you?
Thank you. See if we can get one or two more questions in here. So one question here on what are your thoughts regarding the relationship between advanced care planning and shared decision making? I'm sure there's more detail than that, but maybe you could comment.
Yeah. So I see shared decision making is decision making, and it's in the moment decision making. So for example, early stage prostate cancer, and you're trying to choose between surgery and radiation. There's been a spectacular amount of shared decision-making work around that choice. That's a choice somebody has to make that they're going to go one way or the other right now. And that's an in-the-moment decision. That's not an advanced directive or advanced care planning. I think advanced care planning is trying to sort of do shared decision-making for decisions you're going to make in the future that's hypothetical that you don't know about yet. And that's where I think it's problematic.
Great. And then a note here about comment about how it can be difficult for clinicians to give up on ACP. Feel like we are having a meaningful conversation, but you were recommending moving that conversation to the time when the decision is occurring, not in the abstract earlier.
Yeah. So I think the problem, so I have lots of meaningful conversations with my patients early on. We just don't talk about whether or not they should be DNR or whether or not we're going to put them on a ventilator or a feeding tube or whatever. We have meaningful conversations about what's most important. We have meaningful conversations about what their hopes are, about what they're worried about, What are their fears about the future? What's most, what are their values? What are they like? Those are very deep and meaningful conversations. What things, existential things, concerns. We can have all those conversations. I just don't link them to a treatment choice at some point in the future.
Great. Well, I'm afraid we're going to have to leave it at that. I do see there are a couple of more comments and questions in the chat, so we'll try to capture those. But let me just end for now because of the time, and we need to close. But thank you, greatly, James, for joining us today, and again, I'm sure everybody else as well is very grateful for your prodding on this issue and pointing us into thinking more about the evidence and what it's directing towards. So thank you, Dr. Tulsky, and thanks everybody for joining our seminar. Great.
My pleasure. I'm glad I could be here, and think again. And if people are curious, please, I'm welcome to receive emails and so forth.